Hello, welcome to another of our surgical pathology digital slide review and sign out sessions. I am Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy, which is a joint venture with Path Presenter and the Digital Pathology Association. We certainly invite you to join the Digital Pathology Association because membership there has great educational advantages and is free to trainees and individuals from developing and low-income countries. So our case today comes from the realm of GYN pathology, as you know, one of my passions, and an area where I continue to learn things. And this is to share a little bit of what I've learned from a particular case that came by our desk recently. So the woman is a 59-year-old person who has abnormal postmenopausal bleeding, a very common symptom and presentation for various tumors as well as other disorders. As you can imagine, the differential is fairly broad, but neoplasms are near the top of the list. But we shouldn't forget that infection or vascular disorders, hormonal issues, even trauma, and occasionally even thrombotic coagulopathies and other synthetic problems can be a source of bleeding in this age group, along with the more common lesions. So this patient had a curettage specimen performed, and this is fairly representative of what was seen on that curettage. As you can see, we have what looks like some bluish endometrial type tissue and a fairly large area of very hyalinized pink tissue, very low cellularity and a high degree of collagenization in this tissue. So this is fairly characteristically seen in endometrial samplings, oftentimes following implantation. As we know, the placenta can induce a sort of hyaline scarring with a decidual reaction. And so with that presence of that kind of tissue fairly broadly in this sample, the reviewing pathologist made a diagnosis of a benign endometrium with probable placental site nodule, and plans were made for further therapy. However, when we came back to review this case following resection, there are a few additional things to notice here. One is there's areas of fairly high cellularity in this tissue with some sparing around the glands and a degree of atypia in some areas in this fragment. And of course, this was just one of several slides. Additionally, we have areas like this, which show increased cellularity, and you might think, well, that's just benign stroma. And let's see if we can come here a little bit more. Up in here, I think we begin to see a little bit greater degree of some degree of atypia in this stroma. Particularly here, where there's just a little bit of variability in the stromal tissues. So it's not very convincing at this point, but because there were several of these kinds of areas on the other slides as well, we were struck that this presented a learning opportunity. So the next, as I've indicated, the next situation was the resection specimen. And in fact, here is that specimen. And we see grossly as well as microscopically that we have a tumor that is invading the myometrium. Here's the serosa here to the right. And here's this pale blue tumor, which has very little in the way of glands, just a few slit-like glandular spaces. And as we see here, it has areas that look like they are bulging into vessels. It's a mesenchymal lesion with a sort of a sarcomadoid pattern. It's not a really ultra high grade anaplastic type sarcoma, but it's certainly reasonably cellular. and somewhat spindle and epithelioid appearing. It doesn't look like, particularly like endometrial stroma per se, but and the pattern of invasion is not quite the worm-like invasion that you often get with that, but it's certainly an infiltrative pattern. Now, how did we get there from placental site nodule? Well, as we looked more superficially at this tumor, we noticed that here in the superficial portions, in fact, we do have this very prominent hyalinized tissue, such as was seen in the curettage sample. And that this is sometimes interspersed with more cellular areas of stroma, and then areas such as this. And there were plenty of other sections with this type of morphology where you have a very bland surface epithelium and this fairly cellular and mitotically active stroma just beneath that. In addition, there were some areas of more loose stroma and some areas more condensed around that. So based on this pattern, which was fairly broad and widespread, the admixed glands in this tissue, and here we see a gland with underlying high-grade condensed stroma in this particular field here, we made the diagnosis of adenosarcoma with greater than 25% sarcomatous component and therefore sarcomatoid overgrowth in this sample. So that was a very sobering experience. Fortunately, there was no particular harm done. The surgery would have been the same. The interval between diagnosis and surgery, or biopsy and surgery, was not adversely long. And so I think no harm was done to the patient, but the lesson was certainly learned. So as we think about differential diagnosis of tumors that may have a biphasic appearance, of course, there are a number of benign ones, the polyps, adenofibromas, adenomyoma, atypical adenomyoma. Carcinosarcoma classically has a biphasic appearance with both high-grade carcinoma and sarcoma, even heterologous elements. Embryonal rhabdomyosarcoma, which we'll present a few cases in a later video, also can have this biphasic appearance of a stromal tumor with some association to the overlying benign epithelium. Endometrial stromal sarcoma is not classically a biphasic, but may occasionally entrap benign glands and give the appearance of being pseudo-biphasic. And then outside the uterus, of course, polypoid endometriosis can present this kind of biphasic appearances as well. And to our differential diagnosis, then, we would have to also add entities with hyaline fibrosis, old placental site nodule, and some of these other entities, polyps and so forth, that can also have hyaline type fibrosis. Adenosarcoma, as we've indicated in a prior video, is classically defined as an epithelial component that is benign with a malignant stromal element. It comes in three flavors: low grade, high grade, and sarcomatous overgrowth, the current case. The grading based on the degree of cellularity and mitotic activity in the stromal component. It does occur over a fairly broad age range, but is usually peri or postmenopausal in the majority of cases. And the uterus, cervix, vagina, these are the most frequent locations, the uterus being the most frequent, but it can arise in other locations, particularly those sites that are associated with endometriosis. So it may have an endometrial type origin in some cases. Prognosis is relatively good, although with myometrial invasion or a high amount of sarcomatous overgrowth, that prognosis goes down. Similarly, with high grade or stage, the tumor can be potentially lethal in those instances. There's a variety of molecular events going on that can include mutations with ATRX. MDM2 usually has a low grade level of amplification. FGFR2, KMT2C, DICER1, TP53, MYBL1. These are all lower frequency mutations that can be seen in these tumors as well. So just to contrast this, I thought I would include a couple of examples of adenosarcoma without that same degree of hyaline fibrosis. So here's some curettings. And as you can see, there's a mixture of glandular and a fair amount of stromal elements here. So you might think about kind of an endometrial polyp type of pattern. But as you look and you notice this, there's a bit of condensation here around the epithelium, which is quite characteristic of Mullerian adenosarcoma, as it would be with embryonal carcinoma or embryonal rhabdomyosarcoma, excuse me. And as you come into higher magnification, you might see how this tissue in these subepithelial zones is more cellular, maybe more inflamed and active, while the epithelium is clearly benign. And here you see some of that higher grade appearance of some of these cells in these areas. On a resection sample, coming on with the next slide, here you'll see how it has a polypoid appearance. Sometimes you can get broad leaf-like growth, sort of phylloides-like, either within a cyst or more exophytic on the surface, as some of these areas here appear to show that phylloides pattern of leaf-like growth. And again, the cellularity in this particular area in the stroma is not high. This would be a low-grade area with just this very low-grade appearing sarcomatous elements, not normal endometrial stroma. And these, you would find mitoses and some degree of atypia in this, but with a benign appearing epithelial component. So these can be somewhat deceptive in a variety of ways, both in the low-grade side of things and, as we've just witnessed, in a higher-grade sarcomatous overgrowth area where there probably was a long-standing type of lesion of this sort that then dedifferentiated and became very hyalinized and fibrotic over time, leading to the misinterpretation as a placental site nodule. So that concludes our discussion for this very interesting case. I hope it's expanded your differential diagnosis. Our final sign out was Mullerian adenosarcoma with sarcomatous overgrowth and areas of hyaline fibrosis mimicking placental site nodule. I hope this has helped your learning, and that if you like this, you'll hit that like button. We do also welcome you to subscribe. We hope to continue to produce these videos as educational tools and helps in your training and care of patients. I would point out that this really grew out of a quality improvement effort, and that part of pathology is always instructive and humbling as we learn from our mistakes as well as from our successes. And so wishing you the best of many more successes than failures or mistakes in the coming days. I want to thank you for joining me, and we'll see you next time. Thank you so much.